So before we start ECMO, we should know in general who is considered to be the father of ECMO. It's Dr. Bartlett. A very good MCQ question. And so in 1950s, there was a development of the membrane oxygenator in the labs. And in 1971 was the first successful case done by Dr. Bartlett. And 1972, first successful pediatric cardiac case was done. 1975, the first neonatal case was done. And this is the girl Esperanza at 21. And after that, from 1975 to 89, there were a lot of trials in ARDS because before this, ECMO was basically used in cardiac cases. In 2009, we had the publication of the Caesar trial, which led to a significant growth and faith in the use of ECMO in ARDS cases. And as we know, after 2009, we've had a lot of swine flu and bird flus, and now latest COVID, having a lot of ARDS cases where ECMO has been used very well. So this is how in 1971, the ECMO machine with the patient used to look. Was very confusing, very large, lots of pipes. And this is now how compact the ECMO machine looks in the present day. So what is the principle of ECMO? A desaturated blood is drained via the venous cannula. This desaturated blood is sent to the oxygenator where the carbon dioxide is removed and the oxygen is added. It's like an artificial lung. And then the blood is returned back to the systemic circulation. So this also uses a pump which works as a heart. So you have a heart-lung machine to help the patient. ECMO serves as a bridging therapy. We have to remember this. It is not a curative therapy. It is not a treatment for something. It is a bridge to recovery. That is, it buys time for patients to recover. It is a bridge to decision that before you decide what is the next step, you can put the patient temporarily on the ECMO. Or it is a bridge to transplant in case of, you know that the patient is not going to recover. You're waiting for a lung transplant or a heart transplant so that you can put the patient on ECMO while waiting for suitable organ. So before we start, we should know the basics of ECMO circuit and what it comprises of. So it has a blood pump. The blood comes out through the ECMO from the patient. Then it goes to the blood pump. Then from there it goes to the membrane oxygenator and the heat exchanger. And then it goes back to the patient. For this, you have cannulas in the patient and all these tubings. So all this is part of ECMO circuit. So you have the patient, deoxygenated blood coming from the patient, going through the pump. It goes to the membrane oxygenator, which is supplied by air. And then the oxygenated blood comes out and is sent back to the patient. This is a simple diagram for the ECMO. The same thing, again, the venous blood going to the pump, then it going to the oxygenator. So this becomes the heart, this becomes the lung, and it goes back to the patient. And there is a small bridge in the middle, the role of which I will tell you later. So pumps. First, we come to the pump. There are basically three types of pump. This is the roller pump, or the impeller pump, or the centrifugal pump. So roller pump, the roll head used to roll and it used to press the tube and propel the blood forward. The centrifugal pump is the pump which is used nowadays. The roller pumps are not now being replaced by centrifugal pumps. The perfusion pressure is controlled by the centrifugal rotation, that is rotations per minute. That can go up from 0 to 4,000 rotations per minute. And it can deliver a flow of 8 liters per minute. It is very reliable for 21 days. And centrifugal pumps are the pumps which are now used nowadays. Then you have the membrane oxygenator. The membrane oxygenator, like we had seen the huge machine of 1971. Now the membrane oxygenators are very compact. Okay, what they do is, it's a gas exchange device. It adds oxygen and removes carbon dioxide from the blood. So this you can see that the O2 goes through these hollow tubes and the blood flows through this, and through the membrane, the diffusion of oxygen and carbon dioxide occurs. This is how a membrane oxygenator looks like. So you have the blood from the pump going inside, going into the membrane oxygenator, and the blood going out of the pump. This is what it is. The gas in the middle, in the hollow fiber, and the blood is surrounding it, and through these membranes, a diffusion of gases take place. So nowadays, silicon membrane oxygenators were used earlier, and now it is replaced by PMP or polymethyl pentene membrane oxygenators. These are better than the silicon ones because there's less leakage and less resistance to blood flow. So what happens is gas exchange occurs in these oxygenators. The oxygen exchange depends on how good the membrane or how easily the membrane allows oxygen diffusion, the thickness of the blood pathway, the surface area of the membrane. If the surface area is more, there is more area for gas exchange, the oxygen in the gas phase, and the rate of blood flow. So if the rate of blood flow is fast, what will happen is it will increase the oxygenation. And CO2 exchange depends on difference in the carbon dioxide concentrate between the blood and the gas. So if the blood has a high concentration of carbon dioxide and the gas which is being sent as low, the diffusion will be faster. Again, the size of the membranes, fresh gas flow. So you want to drive out carbon dioxide because it depends on the difference in carbon dioxide. So you want to keep the gas carbon dioxide low. So you want gas flow to be increased if you want more carbon dioxide to be reduced. Again, blood pathway thickness and the blood flow rate. Now, after that oxygenator, you need to heat the blood to the body temperature. Ideally, it is inbuilt within the oxygenator. In pediatric cases, it is connected separately after the oxygenator in the circuit. So what it helps, it is used for temperature regulation in the ECMO circuit. All this is controlled by control panel, which helps you to monitor the pressure and the blood gases. So what it will tell you? It will tell you the pump flow, how good the pump is flowing. It will tell you the mixed venous oxygen saturation. It will tell you the pump speed, and it also tells you there are pressure gauges will tell you the pre-oxygenator and post-oxygenator pressures. Now we have learned about the pump, which was acting like the heart. Then we learned about the oxygenator, which acts like the lung. Then we learned about the heat exchanger, and now we come to the cannulae, which are inserted into the patient. So ECMO cannulae. So if you see, the aortic wires are wound up to the tip almost. And you can see right up to the tip, you can see the wires, and there is only a single outlet. Like you can see here, there's only a single outlet. This is the arterial line, and the venous are usually having multiple outflow holes. This is because you want maximum intake from the venous side. So these are the French cannulae. So this can be asked to you that what is the arterial French and the venous French cannulae which you put for the general patients. So we put around 23 to 25 French cannulae for the arterial and venous cannula. And in the open chest, you can put a little smaller size, but still 23 to 25 French. These are the Mackay cannulas, the Covidian single dual lumen cannulas. So these are the different companies which are having cannulas. So when you know, you should look at whether it's an arterial cannula, which is a venous cannula, whether it is a single lumen or a double lumen cannula. What is a dual lumen cannula? So in the dual lumen, you have that the blood flow is going into the IVC. So this is the drainage port, and there is a hole which is directed towards the tricuspid valve, which acts as the outlet. So what happens? One catheter does the work of both inlet and outlet. This is a little difficult because you have to place this cannula under echo guidance, and you have to see whether this hole is directed towards a tricuspid valve. So the advantage of the single lumen, single catheter, double lumen catheter is, it is a single cannula with 2 lumen for access and return via the IJV. It allows movement because there's only one cannula. It's easy for the patient to move. But disadvantage is it can get dislodged easily, and it is difficult to position port towards the tricuspid valve. Now tubings. The tubings which connect the cannula to the entire circuit is made of tubings. There are 2 types. They can be regular tubings or heparin coated tubings. Now we learn about the VV ECMO. So what happens in the VV ECMO is,